Persons, and at the outset I would like to thank the organizing committee as well as the scientific chairman for this kind invitation. My topic is talking about the management of diabetes in the elderly, the challenges and solutions. And without much ado, because I have very limited time to talk, I'm going to get into the meat of the talk. Remember that managing diabetes at the extremes of age is rather quite difficult. So whether you're looking at adolescent and childhood diabetes or at the extremes of age, they have their unique set of challenges in terms of control. And today I'm really going to dwell on the other extreme, that is the super elderly and the elderly population, as to how you're going to manage diabetes in this class of people. This pointer doesn't work. The slide change is not working. All right. Remember that while we have a growing younger population, please do not forget that the longevity of the life has increased, and we have a larger number of population which is going to be aged, and sadly so, with a lot of less social security for their management. Having recognized this thought, the IDF has come out with a document, a global guideline as to managing older people with type 2 diabetes. This is going to be the scope of my talk. Let us first address what is the magnitude of this problem. And this was the US consensus data. They looked at initially the 1900 to 2006 data and then projected this data over up to 2050. And you notice over here that the population in the elderly is gradually increasing. So we're going to see in our practice more and more people who are going to be aged, and we're going to deal with the special problems as we come forth with them. And in the next 15 minutes, I'm going to address some of these problems to highlight and show how we're going to deal with them. In India, a third of our population that we treat is going to be elderly. So this is the consensus that came forth. Almost about 30.42% of our population is going to be elderly population when we treat our diabetic patients. Is there a difference when you treat patients who are young versus the elderly population? So what are the differences that we face in treating the elderly population? So while this cartoon shows that the challenges at the extremes of age may be very similar, but we have to deal with some of new problems when it comes to the elderly population. Now, if you look at this graph, we have, of course, diabetic-related complications, and then we have the geriatric syndromes which are peculiar to the aging population. But when these two get together, they amplify each other's effects. So while we recognize that the macro and microvascular complications could be unique to diabetes, there are various geriatric syndromes when it comes to cognitive function, depression, physical disability, polypharmacy, and other geriatric syndromes. So the two together would amplify all these problems in an individual. We do recognize that elderly population have less physical activity, increase in central adiposity, they do lose their muscle mass, and the effects on the beta cell tends to go down. So combined together, they may need to increase in insulin resistance and reduce insulin secretion. And all this may ultimately lead to impaired glucose tolerance and type 2 diabetes. Now, this was a very good paper, and what they looked at is the acute insulin secretory response to oral glucose challenge when you look at the young versus the older population. And what they noticed is that there was an increase in postprandial response, but the initial insulin secretory response was blunted. Now, what does this really add up to? If you look at patients for diagnosis of diabetes with only a fasting glucose criteria, you may be missing out almost 50% of the population who has a glucose intolerance. And this was the enhanced 3 data. So it's imperative that when you're looking at an elderly population, you have to look at also the post-meal glucose values. There is a lot of heterogeneity in the presentation when they come to us. And I'm going to cover most of these points, so I'm not really going to read through this because the subsequent slides will cover this. Remember that while we know the classic symptoms of diabetes, in an elderly population, they may present with falls, urinary incontinence, fatigue, lethargy, mental confusion, weight loss, infections, poor wound healing, and visual disturbances. Hyperglycemia, hyperosmotic coma is not really uncommon in the elderly population. The attitude of the patient can be very important. While one person can be extremely jovial, fine, the other person may be extremely depressed, and this may actually reflect on the glycemic control of the patient. We have to look at this patient from a multitude of ways. If you're looking at the older population, you have to see whether they're functional or not functional. What is the support structure this person tends to have? Does he have enough of support in the house, in the community? What is his economic status, whether he can afford treatment, whether he can afford hospitalization? So it's not just good enough to give a treatment schedule for this patient. You have to look at the other aspects of management too. Remember, this paper was by Medha Munshi from Jocelyn, and what she showed that in the elderly population, 48% tend to have a hearing impairment, 53% tend to have a vision impairment, 33% tend to have a history of recurrent falls, and they may have problems with the activities of daily living and instrumental activities of daily living. Cognition is a very important factor because it's like a two-way process. When patients are not at control, obviously there is a rapid cognitive decline, and when they have a high degree of cognitive dysfunction, obviously it becomes difficult for them to understand the treatment, and that makes them into a poor control and worsens the cognition process. This is one of the reasons that, some of the reasons that you see for cognitive decline, but importantly I would like to highlight repeated hypoglycemia. This is something that we don't recognize in our patients, and repeated hypoglycemia, some of them unrecognized, can lead to a very rapid cognitive decline in the patient, other than all the other factors that have just been enumerated on this. Other thing that we have to evaluate in all our patients who are elderly is the presence of depression, because this ultimately may also affect their control, because if they don't understand the treatments, they don't follow the treatments, they tend to become hyperglycemic, and that tends to only worsen the situation for them. And we have seen that patients who are uncontrolled would tend to have problems with their activities of daily living and instrumental activities of daily living. What this really amounts to is that we have to assess in a clinic very simple parameters. How are you going to assess, depressions? And these are some of the tools for assessment of depression. You may use a questionnaire method, or you can use a two-question screening. Commonly what we use is the clock in the box method. And what it is, basically you draw 4 squares, tell the patient to draw a clock, and then you tell them to make the hands, the big hand and the small hand, and you tell them, okay, draw 10 o'clock, where would the larger hand be and where the smaller hand would be. And they would find that they may not be able to put the clock in the correct box, or they may not be able to identify the hands of the clock, how they are to be put. And there's a very simple method that you can assess a patients for cognition or for depression in your own clinic. So if I have to really look at patients in the elderly, while uncontrolled patients may have problems with their macro and microvascular complications, there are other challenges in the geriatric population that you also have to look at. So cognitive function, depression, polypharmacy, falls, urinary incontinence, and physical ability. And all this ultimately may lead to increased morbidity and functional disability, leading to recurrent hypoglycemias, reduced compliance of treatment, and reduced quality of life. And all this ultimately makes them more hypoglycemic and increases in turn the mortality and morbidity. Now, what should your goals for treatment be in the elderly population? You have to remember that while it is good to have a very stringent control of glucose, you have to balance it in the perspective of the overall risk cluster that this patient tends to have. And I'm just going to elaborate this. It's good to have good control because the benefits are all as enumerated over here, but there are a large number of risks that the elderly population tends to have. The risk for hypoglycemia, CV events, death, weight gains, fractures, heart failure, all these things. Remember that when you are planning a goal of treatment for your patients, you have to look at the coexisting health problems that the patient has, whether he has a psychiatric or cognitive disorder, what are the comorbidities the patients tend to have, are there any limitations in terms of their functional status. Please remember to keep the treatment regime as simple as possible. The more complex the treatment regime tends to get, the more difficult they find to follow it, and they get only more hypoglycemic. Try and keep a little looser control in your patients who are elderly, because it gives them a protection against hypoglycemia. So don't go too tight in control of your glycemic status. Try and avoid polypharmacy as far as possible, and please do address social issues in your patient when you're looking at the patient as a whole. Now, this is a rather busy slide, and what I'm really trying to convey through this slide is whatever the presenting A1C values to you would be, whether you're looking at less than 7, 7 to 8, or more than 8, Your goals are decided whether the patient has comorbidities, what is the risk the patient tends to have of hypoglycemia. So if you have somebody who has a lower risk for hypoglycemia with no or very limited comorbidities, maybe you can go a little more tighter in their control. But patients who have got multiple comorbidities, who are very sick patients, I think you should leave them as loose as possible in interest of their safety. This was a very interesting paper, and what they really showed that they looked at effect of control of blood glucose, blood pressure and lipids, and what it does prospectively over a period of time in terms of macro and microvascular complications. So if you have somebody who you give a very tight stringent blood glucose control, the time to get benefit out of this control for microvascular complications would be about 4.5 years. For macrovascular complications would be almost about 10 years. If you stringently control the blood pressures, the time to benefit for micro would be about 4.5 years and about 3 years for macrovascular complications. And if you tightly control lipids, then the benefits would be seen in about 3 to 6 years. So what really this sums up to is, rather than concentrate on giving the patient a tighter glycemic control with all its associated risks, it's far more prudent to control their lipids and blood pressure, which is going to make a more impact in the near future for this patient. So somebody who's about 70 or 80 years old or 60 years old, it's far better to concentrate on the blood pressure and lipids rather than go too tight on the glycemic status. We know that these are all the instruments of treatment that we have, but the bottom line is try and use agents which would cause less hypoglycemia and better tolerability for the patients. We know that polypharmacy is the rule because an elderly population may have diabetes and other comorbidities like hypertension, IHD. So a number of drug interactions would tend to take place, and you may have a patient who's taking multiple medications. But don't use complex regime in the patient. It's been shown with enough of data that the more the medications the patient tends to take, the looser the control tends to be, because the patient cannot figure out what he's supposed to follow, and then they end up being more hypoglycemic than in a tighter control. So the management of diabetic patients in the elderly population, while we know it should be medications, diet, physical exercise and physical activity, we have to address the risk factors, keep their blood pressure control as low as possible. They should now be 140/90. Improve on their lipids, cessation of cigarette smoking, low dose aspirin where relevant, and of course screen for various complications, whether it's kidney, eyes or feet. But an important part that you have to look for all the elderly population is screening for barriers for control, whether it's clinical, functional or psychosocial. Some of the reasons why the patient tend to get hypoglycemia in the elderly, the patient risk factors would be advanced age, recurrent hospitalizations, intercurrent illnesses, organ dysfunctions, endocrine deficiencies, loss of normal counter regulation. And this is one of the single most important factors that you have to remember, because hypoglycemic unawareness is not at all uncommon in the elderly population, and the patient may just present with either loss of consciousness, or he may just not recognize and may land up with fractures, falls or any of these things. Lifestyle risk factors, where it could be poor nutrition and fasting, prolonged physical exercise, or alcohol consumption, and then drug risk factors, which can be sulfonylureas or insulin or drug interactions with other agents that is consuming. And all this would, of course, lead to hypoglycemic unawareness, cognitive dysfunction, comorbidities, which may lead to non-compliance, falls, or exacerbation of chronic conditions. Now, this was a very nice paper. What it looked at is they had two groups of people. One where the blood glucose was maintained at around 90, and the second group which was rapidly brought down from 90 to about 43. And they looked at the insulin response, the counter-regulatory response. They found a good response or a hyper response where epinephrine and cortisol was concerned, but a blunted response where the growth hormone was concerned or glucagon was concerned. And even more alarming is the fact that the reaction time was delayed in these patients. So they not only do not recognize hypoglycemia, but the reaction to the hypoglycemia can be delayed, and that can be very dangerous. So these are some of the agents that you would tend to use in your patients. This has been a slide that all of us use, but has a lot of relevance in the elderly population. And I would like to end up my talk with the last slide, that older patients versus younger patients, the clinical presentation is different. The psychosocial background is different. Course of the disease and comorbidities you have to address. The goals of the treatment, remember that do a risk-benefit analysis. Should you be more stringent or should you pay attention to risk for hypoglycemia? And always when you manage these patients, match the patients with the complexity of the treatment. Try and simplify the strategies of treatment. Thank you very much.